Dr. Tracey Parnell is a board-certified Canadian physician and researcher who serves as an assistant clinical professor at the University of British Columbia, Global Director of Communications and Development for the International Institute for Restorative Reproductive Medicine, and as a managing editor of the Journal of Restorative Reproductive Medicine. Her training includes a Master of Reproductive Medicine with Excellence from the University of New South Wales and a Certificate in Reproductive Health Research from the World Health Organization and Geneva University. Dr. Parnell maintains her own RRM clinical practice in Canada and is medical director of the RRM Education Group, which brings together leading experts to provide advanced RRM training and education. Dr. Monica Minjeur is a board-certified family medicine physician and neo-fertility medical consultant with a special interest in infertility, recurrent miscarriage, PCOS, PMS, painful periods, and other gynecologic conditions. She is the founder and CEO of Radiant Clinic in Cedar Falls, Iowa. She serves as the U.S. Director of Communications and Development for the International Institute for Restorative Reproductive Medicine. Dr. Minjeur earned her Doctor of Osteopathy degree at Kansas City University of Medicine and Biosciences and completed her family medicine residency at McLaren-McComb in Mount Clemens, Michigan. She hosts the podcast Cycle Wisdom, Women's Health and Fertility, where she educates on diagnosis and treatment of underlying causes of infertility and menstrual-related concerns, sharing her expertise and passion to empower listeners when it comes to reproductive health. Please welcome Dr. Minjeur and Dr. Parnell to the NFP Podcast.
Welcome to the NFP Podcast, where we explore the empowering world of natural family planning. I'm Amy Smith. Join me and my co-host Emily Appledorn each week. Together we're here to dive deep into the science, the stories, and the spirituality behind NFP. Every week we push back against the free love culture and advocate for a culture of responsible love, where intentionality and respect are at the forefront of family planning. Join us as we discuss everything from the practicalities of charting and fertility awareness to the profound impact NFP can have on relationships and communities. Whether you're new to NFP or a seasoned pro, our podcast is your go-to resource for honest conversations, expert insights, and real-life experiences. So grab a friend, settle in, and get ready to be inspired. This is the NFP Podcast.
All right, guys, welcome back to the podcast.
Hi, everyone.
Today, Emily and I are very excited to have on two medical professionals with us. We've got Dr. Monica Minjeur and Dr. Tracey Parnell from the Institute of Restorative Reproductive Medicine. Welcome, ladies, to the podcast.
Thank you for having us.
We are really excited to share this resource with our listeners. For those of you who are not familiar with the Institute for Restorative Reproductive Medicine, which I'm going to probably shorten now to IIRRM because it's just a little bit easier, less of a mouthful moving forward. I think you're going to really enjoy hearing about this organization and all the amazing work they're doing to help women have healthy menstrual cycles and to restore fertility to its rightly ordered working processes. So for both men and women, which is exciting. We haven't talked too much about male infertility and male reproductive issues too, but I know IIRRM does some work in that field too. So anyway, let's get started and hear a little bit about both of your backgrounds. Dr. Minjeur, why don't we start with you? How did you get into this field? What's your professional background and what led you to restorative reproductive medicine?
Yeah, so thank you. And thanks so much for having us today. I'm really excited to be chatting with you and your listeners today. So I am by background a physician, and when I went through medical school training, really was fascinated by everything that had to do with women's health. And during my training, though, I had a cousin who was a year older than me, and she unfortunately developed a blood clot in her leg. And it was determined that that blood clot was from being on the birth control pill. They didn't find any other reason why. And so here I am as a medical student thinking, okay, I'm supposed to be this female physician going out in the world, providing women's health to other women, but yet these medications that we're being told to prescribe can cause these very serious side effects. And so it really got me questioning, well, what else could I do? And And for a while I thought, well, maybe I'll just go be a surgeon or a psychiatrist and like not have to deal with those pieces. But then was fortunate enough to come across an individual who he said his brother practiced restorative reproductive medicine. And I didn't know what that meant. I had no idea the terminology, but went and actually ended up shadowing that physician and opened up my world to, naprotechnology and restorative reproductive medicine and all these other things that I could do as a physician. And so I was lucky enough to learn about it early enough in my career that I went through that training as a resident. And so then when I came out into practice, I was already prepared to just break out into the world this way. And one of the great things about that is that when I went to go and interview as a brand new physician to places, I was a little nervous because I thought, well, who's going to hire a female physician at a general practice office that doesn't prescribe birth control? And what I found was everybody wanted that because they wanted something that was different. And so I was able to say, it's not that I don't offer birth control, but it's that I do offer this amazing life-changing medicine that not many physicians were trained in at the time. And so that was how I got my start as far as just in general practice. And then over the next 10 years, had a thriving general practice. And then about 2.5 years ago, split off and created my own clinic. And so now all I do all the time is restorative reproductive medicine, and I serve both women and couples. And then as in addition to that, have developed a lot of close alliances with other physicians and, not only nationally here in the US, but also internationally. And so that has led me to the International Institute. And so I currently serve as the US Director of Communications and Development. And I'm also a part of another organization, Neo Fertility, which is a version of restorative reproductive medicine. And so I serve as part of the medical board for that as well. So have really been honored to be able to kind of get my hands in a lot of different areas within medicine. But that's kind of my story.
That's excellent. Yeah, that is one of the things that I know we've had Dr. Marguerite Duane on the podcast, and we've talked about facts before, but it's so incredible when we can reach medical professionals during their educational years, because then they can kind of hit the ground running when they start practicing, and they can be ready to offer these women the alternatives. And I love the way you framed that, because I think it's really important to say, like, instead of looking at what I don't do, look at all the amazing things I can do. I'm not offering you this treatment, but I'm offering you kind of root cause solutions. Like, I'm not doing that, but here, let's find out like why that's actually happening. And I know I've shared already, and Emily and I've talked about this, but like, part of my story was an encounter with a medical professional who told me like, well, you can go on the pill, but it's not going to like give you a period. And it was like mind blow, like what? I never heard anyone in a white coat say something like that to me. So it's refreshing, especially from the patient population, to have a physician offer you alternatives. I find that to be really encouraging. So that's excellent. Thank you so much, Dr. Minjeur. Dr. Parnell, how did you get into this field? What's your background?
Well, it's actually quite a lengthy story, which I won't bore you with all of the details, but it has a lot in common with Monica's experience, seeing women who either had side effects or who the solution to their problem wasn't in conventional reproductive medicine. And I had one case in particular early on in my career when I was actually doing some locum work at a military base while I was doing my my specialty training. And this woman, I think I was changing her medication yet again, and she was frustrated because I wasn't answering her question. And she slammed her hands down on the desk because it was a short appointment. And so we just did it in my office. And she says, "Dr. Parnell." And I remember thinking, oh my gosh, she's going to hurt me. And she said, "What is wrong with me? And how does this fix it?" And I just remember this feeling that, my goodness, I can't answer that question. So I told her, let me do some research and I'll come back and try and answer. And of course, when I went back to my textbooks and online resources and research, I realized that, in fact, I wasn't fixing anything. I didn't have a genuine diagnosis, despite this patient having seen multiple OBGYN colleagues. She didn't have an answer. And I was upfront with her, and that sent me on a very long journey where I encountered people who were using restorative reproductive medicine techniques, and there wasn't a term for it at that time. There was various fertility awareness methods, but there wasn't really a term for what is this practice of medicine, what is the specialized area of medicine that we are doing. So a group of us actually met in London, in England, and we're having further discussions, and this had been over a long period of time. And the term restorative reproductive medicine was something that was proposed and defined, and everyone loved it. They're like, my goodness, that's exactly what we're doing. We are restoring reproductive function, and we're avoiding methodologies that are inherently suppressive, destructive, or simply circumvent the problem. And if we define this field of medicine in that way, it forces us to be able to provide answers to the patients. And that has been a transformative experience for all of us in our clinical practice, and I think for our patients as well. When they come to us as RRM clinicians, our goal is answers. Now, of course, depending on what they come to us for, I do a lot of PCOS work and obviously infertility and endometriosis. But irrespective of why they come, they become empowered with knowledge about what's going on in their body. They become the expert, and we help facilitate them knowing and understanding that. But then we use the information they bring from their cycle charting, and we're able to use that to, number one, identify abnormalities or risk of abnormalities based on the pattern, similar to an ECG, a heart tracing. And then we can use it to fine-tune investigations, whether that's ultrasound or hormonal testing. We get a really good picture of what's going on. And then we can use that same information to correct the underlying problems. And there's inevitably more than one problem. And you start correcting each one of these complex issues, and you actually improve their health. And you can see that in their cycle charting, because it goes from all these identified abnormalities to, wow, that's normal looking. And then you confirm that, interventions to check for ovulation, say for a fertility patient. And the patient feels better. They know their body is improved. They can see it. It is an objective measure of what they are experiencing. So, and from all of that, the International Institute for Restorative Reproductive Medicine was born, and our goals and functions are to support colleagues to get this training, to make sure that people actually know that this is an option for them, and develop into a specialty that's recognized. Now, that is a long process, and we're 25 years into it. But we've come so far, and I think we're seeing it in patients and, amazing physicians like Dr. Minjeur, who's, this is what she's doing. This is what field she wants to practice in. That's exciting for us.
Yeah, absolutely. I'd love to hear both of you share, your thoughts on this. So one of the things that medical professionals go to school for a really long time. And I give you a lot of credit for that, because that's a lot of schooling. But I feel like in my experience working with medical professionals that are not using a restorative reproductive medicine approach, it feels somewhat sad to me, because I always think of medicine as science, you know, as someone who's like, there's an issue and you understand human biology, you understand physiology. Okay, presenting with these symptoms, like what are the systems in the body that might contribute to this? It's like, you know, you enjoy, I would think, the kind of the puzzle of it, like what's going on here, trying to figure it out. And oftentimes, my experience working with women, it doesn't feel like you really encounter like the love of science when you go to the doctor for 15 minutes. It's like they pull out a book and they say, "Oh, here's the pill that matches that symptom." I'm like, "Why did you spend so much money and time going to school? I could be a doctor." Like, no offense, but I'm like, if being a doctor is matching a symptom with a prescription, really I could do that. Like, that doesn't really take much, you know? And so one of the things I love about encountering doctors who use restorative reproductive medicine approaches is it's like I get excited for the profession, even though I'm obviously not involved in the profession. It's like, it must feel good to feel like a scientist, like to feel like a doctor. And maybe you don't know the answer right away, but you have the tools and you can reach out to your colleagues and you can do the research and you can figure it out and you can try different things and like, I don't know, it just seems like it would make work enjoyable and exciting and interesting and not so like dull and on a conveyor belt of like get a patient in, get a patient out. So I'm curious if that you would say that's been your experience. I also recognize too, it does add an element of challenge, right? Like because you're not just saying, symptom, textbook, this pill, here you go, out the door. You know, you have to work a little harder and you got to think more and you got to investigate and maybe you're wrong sometimes. So anyway, your thoughts on that? Maybe we'll start with you, Dr. Minjeur.
Yeah. So I think for a lot of us in restorative reproductive medicine, our favorite question we always joke is why, right? Like, okay, well, testosterone levels are low, but why? Oh, because they're stressed, but why, right? Like sometimes my staff gets annoyed when I keep asking why, how many times, but you're right, you nailed it. Like that's for me, the puzzle, the detective work, all of that digging to really get to what is the very most underlying cause that we can find is extremely rewarding. And I think even more so, we see that in our patients that we serve on a regular basis. All of us probably daily are hearing stories about this is the first time I feel listened to, or this is the first time a doctor actually cared to ask my symptoms or to dig deeper or to run that lab test. And on one hand, it's really sad that, you know, sometimes we're that first approach after they've seen 6 or 7 other people. But on the other hand, to be able to bring hope into that world is so rewarding just as a professional, but also just as a human being to help and to touch other people in that way. And then the other piece, you know, kind of as you had mentioned, one of the big challenges with this is how do we provide this level of expert care in a setting that makes sense? And that's one thing that we're discussing a lot, especially here in the US. You know, we are an international institute, and so there's different nuances in different countries. But, you know, certainly for me, I have always practiced restorative reproductive medicine, but for the first 10 years of my practice, it was in that setting where my appointments were 15 to 20 minutes a piece. And now I spend 60 minutes with each of my patients, right? And so finding ways to make that work in a way that not only is sustainable from a business standpoint, but also that helps to say, yes, I need to still be able to see X number of patients. And so there are absolutely some challenges with that. I know here in the United States, many physicians that practice this way are going to independent private pay practices because of that. And it's really hard. I always joke, I would give away my care for free to everybody if I could keep my business afloat. But really it's challenging to say if in order to spend that amount of time and energy with the patients as they deserve, there has to be some give and take. And so that's a lot of the pieces that right now we're trying to navigate. What makes the most sense? What is sustainable? But also what helps us serve the most patients in the most meaningful way. So absolutely great that you pick up on those nuances because it's tough, but it's also, you know, it's so rewarding. So it makes it worth it. But man, the challenge of making it all happen sometimes is tough to go against kind of what the conventional medical system is right now in the US.
Right. And, you know, I think medicine is just one of those fields that's so ripe for innovation, you know, whether it's like blowing up the insurance model, like whatever it is, you know, just trying to create new things is always challenging when you're at the beginning level of that, so who knows what will be like in 10 or 20 years. But yeah, being on the front lines in the beginning can be quite a challenge. How about for you, Dr. Parnell? Do you find the challenge invigorating to your practice or not so much?
It's some of the most rewarding practice I do, because of the time you get to invest in a patient. And because the patient is so empowered, it's very hard when the patient knows absolutely nothing about their bodies or their condition. And these patients truly want to know and understand. I do want to, comment that when we talk about conventional medicine, as you were describing, computer symptom thing, I mean, I just thought, my goodness, we're so easily replaced by AI at the moment, because literally, this is the solution for 1,000 different symptoms. And we really want to return to the standard approach in medicine. Find a problem, fix it. We're medical detectives. That's what we do. And if a patient in any other field of medicine, let's use an example, if you came in with a cough, you said, Dr. Parnell, I've been coughing for 6 weeks. And I said, here's your antibiotic. Thank you very much. If you happened to have had a bacterial infection, I would be superhero. But if you had tuberculosis, cancer, asthma, all of these other things, my treatment would be not beneficial to you. And in fact, significant potential for harm by ignoring the fact that this cough is a symptom. So a lot of the work we deal with is infertility. Infertility is not a disease. Infertility is a symptom of multiple abnormalities. And I read a document recently that came out and said, infertility is a disease, and oftentimes we cannot figure it out, and that's unexplained infertility. Honestly, within restorative reproductive medicine and our published studies, the rate of unexplained infertility is less than 1%, dramatically less than 1%, because you find the reasons when you look and and have the tools to be able to do that. So incredibly rewarding, very medical detective oriented, and patients deserve answers. And when you're in a position to provide that, it's rewarding in all manners except usually financially. But, and I'm not practicing in the States, but I think globally we see the same thing, that it's very difficult to find a model of care that allows you to spend an hour with a patient, because that's really what's required. But I'm impressed that there are certainly some new and exciting ways to deal with that, and the patients deserve the answer and care that's being provided.
Yeah, I think you bring up a really good point, is the I don't know what the term is, would it be like stonewalling or what, but when it feels like sometimes like you're just kind of giving me the easy answer, oh, it's unexplained infertility. I'm like, really, it's unexplained, or you just don't know the answer? Like, I would just have so much more respect if you just said, like, I don't really know, but there's got to be some reason why, this is happening for you. And if we just did a little bit of investigative work, and this is not to throw, physicians who don't practice restorative reproductive medicine under the bus. There's so many reasons why they might not be practicing that. A lot of it, I think, has to do with just ignorance, like a dearth of knowledge and awareness about it. Obviously, a lot of medical school curriculum is not tailored to this type of practice of medicine. So, giving your physician the benefit of the doubt, this episode and this conversation is definitely not to stir up, too many negative emotions, or to, hate your doctor for their traditional way of practicing medicine, or this kind of the standard way of practicing, but more to expose everyone to, there are physicians who are really interested in finding the why and believe there is a why, and exploring the different solutions to that. So let's take a moment to talk about, and thank you, Dr. Minjeur, for pointing this out, because I failed to correctly give the full name for the IIRRM, which is the International Institute for Restorative Reproductive Medicine. I left out the international part. So globally, there's this collaborative of medical professionals who are communicating and sharing research, looking at, these underlying causes of, whether it be infertility or other reproductive diseases and disorders, and trying different treatments and different practices. And you guys are sharing the solutions that you're finding, successes and failures, et cetera. And so can you maybe shed a little bit of light for our listeners on that aspect? Because I feel like, correct me if I'm wrong, but that's kind of like the meat and potatoes of IIRRM, is this connection with amongst medical professionals to share research, to get solutions out there, to help provide everyone with resources to say, hey, we ran this study, we tried this, solution with progesterone to help with this postpartum issue, whatever it may be, or PCOS, we tried this thing, or endometriosis, we've tried this, or male infertility, we've tried this. So I guess maybe you can elaborate a little bit on that, because I'm sure I just did a really bad job explaining it. So would you say that's kind of the primary work of IIRRM, or would you say it's something else? Dr. Minjeur, let's start with you.
Research is definitely a part. Always from the beginning when IIRRM was founded, we knew that needed to be an important part of our work, because there just wasn't any research out there about what it was that we do within RRM. And so, yes, that is an integral role, not only gathering data, but also helping to produce research. We've recently founded a journal for restorative reproductive medicine, where people from all walks of life, not just RRM physicians, can publish within our journal anything that applies to the field of restorative reproductive medicine. So that is a part of what we do. But probably even a larger part is just ongoing education, collaboration. So we have monthly case reviews, we have monthly grand rounds, we do review of other research articles that aren't even within the field of RRM. We do a lot of advocacy work. We've been doing a lot of media work, talking to people within the media to help them to understand what restorative reproductive medicine is. We work to collaborate and say, how can we bring about what is the RRM protocol for how we treat XYZ, fertility or PCOS. So there's a lot of other pieces that we do. And again, as we look at kind of our breadth, we span over 50 countries, hundreds, if not thousands of members. And so really within each of those communities, it serves a little bit different purpose as far as how it's helping to bring people in. We have at least annual conventions that we host, and people come from all over the world as well as virtually. And so just a lot of pieces that not only foster that ongoing community, but absolutely add to the education in addition to the advancement of research. So yes, research is a core component, but there's so much more that we do beyond that. So, and I would love to hear Dr. Parnell's answer on this also, because she's been there from the start as far as if there's other pieces I missed beyond those.
Right. I mean, I think you summarized them quite nicely. The reality is that we're the professional society representing restorative reproductive medicine. And as the professional society for RRM, we have the obligation for all the aspects that Monica outlined. So research, publications, education, setting the standards for what is RRM. Who can say that they're an RRM physician? It's become a term that a lot of people are grabbing onto, but we actually do require training and ongoing expertise and demonstration of that for someone to be considered an RRM clinician. So we have those obligations, and then the patient is really our focus as well. We provide the clinical people the resources they need to ensure that they can provide their patients with the best possible care, and that's anywhere in the world. And so we just really have an obligation to move forward and make sure that this is done in a professional manner and supported to accomplish our goal of becoming a specialty in the future.
And what area of medicine or medical professionals do you collaborate with or support? Is it OBs? Is it family medicine? Is it nurse practitioners? Is it everything?
Right. So we have what we call core specialty trained individuals. So currently, most of our people come with either an OBGYN background, family or general practice, depending on, again, what country they train in. Internal medicine, endocrinology, both of those have interest in. And we, of course, provide for mid-level trainees as well. So that would be your nurse practitioners, your physician's assistants, depending on where in the world we're providing their training and their support. So, and I want to emphasize, restorative reproductive medicine is not just the doctor. In the same way that an IVF clinic is a team, an our RRM clinic is a team. So we have coaches, we have obviously fertility awareness, cycle instructors, whatever term is used in that particular part of the world. We have the clinical personnel, we have the nursing personnel, the administrative personnel. It is a team. And that team is really what is empowered to make a difference for those patients. So we help to try and make sure everybody has the connections and expertise to do that.
That's excellent. Dr. Minjeur, I wanted to just highlight something that you said when kind of the IIRRM first came on board with looking at research, recognizing there wasn't a lot of research, which I think for the patient population, it's really important to hear that, because while I do think it is important to trust your medical professional and, recognize that they have expertise, it's also important to know that if you're not getting answers that you feel comfortable with or that you think are, total or as in depth, if just kind of the flag goes up, it's okay to get a second opinion, like to kind of keep doing some research to say, maybe they don't know the answer, but that doesn't mean there isn't an answer. Just because the first doctor I go to says, well, IVF is going to be your only option for having a baby, that might not be accurate, and I think that's one of the big takeaways I want people to have from here is, there's a reason why, you're not able to ovulate or get pregnant or whatever, you're miscarrying. Like there's a solution there, and there are people who are trained and are training to find those solutions. So I think it's really telling that, sadly, right at the start, it's like, oh gosh, there really wasn't a lot of research looking into the whys of why is it's happening and what are some of those solutions. So it's amazing. It spans 50 countries. I just find that so encouraging and just so hopeful. Emily, jump in here. What do you have questions?
Yeah, I'm just wondering, what does training look like for a physician that's interested in being able to, practice this form of medicine and establish a relationship with IIRRM?
Well, that's a great question. Maybe I'll talk about sort of where we're going and what's coming soon. And then maybe Dr. Minjeur can talk about our clinician recognition program, which is currently in existence. Again, this is a process. So we do require that RRM clinicians are trained in more than one fertility awareness method. For much of our work, you need to be able to empower the patient to know and understand their body with science-based, usually instructor-led fertility awareness or cycle-based tracking. So we ask them to come with whatever their baseline training is. We add or give them available options to have additional. What we don't want is we don't want patients who said, oh, I trained in the Billings method. You go to this physician and it's hard to find physicians who are at least interested. And they go, oh, well, I'm this instructor, or I want this type of charting. In some circumstances, different charting is useful for different types of patients. And as a clinical provider, we want our RRM experts to be able to help the patient know what is the best option for them at that stage of their life. So we want them to have a broad experience. We are quite excited to be launching in the near future, and we're waitlisting this currently, our fellowship training program for restorative reproductive medicine. So this will be a 1 year plus training, which will be sort of a standard academic year. So if a clinical physician had come out of family practice or any other field of medicine and they were going to do a year of additional training, this will follow the same format. There will also be opportunities for clinicians who may not have the same desire to take a year off of clinical work, and they will be able to do a certificate which will cover all the didactic material, but perhaps have a little less clinical mentoring. So clinical rotations may not be as intense for the certificate course, but they'll still have that opportunity. So that's where we're going to, just like any other profession, any other specialty that evolves. You have baseline training and you have continuing medical education webinars, and you set a standard, and then you evolve to further standards that we hope to see eventually incorporated into medical schools, etc. Dr. Minjeur, did you want to talk a little bit about our CR programming?
Yeah. So one of the things that we've developed is this restorative reproductive medicine clinician recognition program. And so it was developed with a few key pieces in mind. The first is to really recognize and call out physicians and other healthcare professionals who are providing RRM care, and also to help continue to encourage clinical excellence and ongoing improvement. So knowing we're keeping up with those education requirements. We're seeing more recently a lot of people are kind of latching onto this term of RRM. And even some people are saying, well, I'm an RRM physician or I'm an RRM clinician. And when you go back and look, they're like, wait, you've not done any fertility awareness-based method training. You don't have any of this restorative reproductive medicine training. And so we've developed this clinician recognition program to really call out, okay, yes, this is somebody who our board has reviewed is an individual who has been approved, who has gone through the appropriate training in order to be able to practice medicine in these ways. It also allows us to maintain a list of clinicians who are actively practicing, right? So that we can either help to connect our patients to who are looking, as well as provide that network of other clinicians to work within. And so, there's some key steps, and that's available on our website for any clinicians who may be interested in that process. But really, again, it goes back to that, just creating that high standard of care as far as what we hold ourselves accountable to as a medical society. These are the terms in order to say, yes, I am a practicing RRM clinician who is recognized by the IIRRM.
Yeah, I could see how that would be important, especially because it sounds like, the focus of IIRRM is not so much we don't provide these services, but we do all of this, really focusing on the what we do as opposed to what we don't do or what we don't offer. So yeah, that's excellent that there's that standard, kind of like that seal, of approval, if you will. Like, yeah, you guys have been the stamp to say, yep, this is truly an RRM practicing physician. So aside from the, medical professional, healthcare professional, what you guys offer for them, and we'll link in the show notes to some of those things that Dr. Minjeur and Dr. Parnell have already mentioned. What can you offer to the patient population? We've tried on this podcast to offer them a lot of resources as far as learning different methods. And I have to say too, I haven't been in this field probably as long as both of you, but over the decade that I have, it's so encouraging to now see that there are trained healthcare professionals who, regardless of the method, me as a user of NFP or a fertility awareness, regardless of the method I'm using, you will still take me as a patient. Like, I don't have to switch and learn a whole new charting method just because, you only know this one thing or you feel comfortable with this one thing, which to me makes a little sense, because even though the coding and the charting and the terms might be slightly different, like, the cycle's still the same, and we're still basically talking about the same biomarkers here. It's like, can't we just translate it ever so slightly? So I find that really encouraging that IIRRM is really trying to say, like, look, you have to be able to, speak multiple languages, if you will, even if the dialect is slightly different. We're not even talking about across the world different languages. It's really just slight different variations in it. So that being said, what do you offer, I guess, or what does IIRRM, what can they offer to the patient population, to the kind of the general community, if they're interested in seeking out some of the resources that you all offer? Sorry, either of you can answer.
Yeah, thank you. I'll mention a few things. First of all, we do have different levels of membership. Obviously, we're a medical society. Most of our work is with medical professionals, and our regular membership is limited, restricted, or encouraged to be medical professionals. But we have our allied health professionals. So other people of the team are also part of the International Institute for RRM. And we have a community membership access, which is only $50 US, And that actually gives patients access to considerable wealth of resources that we have online. Now, those resources are notably mostly for physicians, but this is a very educated population, and they may find that the thousands of hours of continuing medical education and the ongoing rounds, etc., may be very appealing to them, or they may find something very specific that is useful. We also have recently, like in the last little bit, offered an enhanced program for connecting patients with a RRM clinically recognized professional. So on our website, there is a button that says, I think, find an RRM clinician or clinic, top of the page. And if a patient is not sure or doesn't know where to go for RRM care, the International Institute for RRM will help you find that person. So there's a form, you fill out the form. It does take a few days. We are not, I guess, shockingly, given the increased interest, particularly in the United States, that service is being very well utilized recently, and perhaps will be more so after you publish this podcast. But we really want to be able to match people looking for genuine RRM care with clinicians that we know have met that standard that Dr. Minjeur mentioned. So we also have, so the button is important and that's preferable, but if someone's just looking for an email, it's RRM, the number 4, me at IIRRM.org. So that's an email as well that people can reach out and ask questions. The preference, though, is fill out the box. It's going to ask you some questions that will make it easier for us to find the right person for you.
Excellent. Yeah, we will link all of those, the button link and then the email address in the show notes. Were you going to say something, Emily?
Oh, I was just going to say that's amazing, even from the start, that IIRRM is willing to take into consideration just a few different things and try to match the patient with the right doctor. They don't even, in my experience, I mean, that wasn't even something that I even felt like happened in person, as far as just trying to get answers. I don't know. I feel like even from the get-go, the patient probably feels seen. And I feel like that has got to feel like they're on the right path if they're looking into being connected with these physicians. It can only give hope, I think.
Right.
So it's really great.
And
That's
to be clear, go ahead. I'm sorry.
I was just going to say that's really the goal, is we want them to feel as they start this journey that we are listening. All of us in the RRM community work together. We're not, oh, they took my patient. We're working together. I send patients to clinicians in the States who have a special focus or surgical aspects that they need to do. Patients who are traveling over to Europe, I connect with colleagues there. This person's progesterone level, they're 8 weeks pregnant. It's a collaborative community, but it's patient focused. And from the very onset, we want patients to feel we're here and we're doing our best to listen. I mean, we're all human, we all fall down, but we want this to be a different experience for them than what they may have had. Not all, obviously, but what they may have experienced previously.
That's beautiful. Thank you.
Let's stay on the focus of patients for a second, because I'd love to hear both of you share a little bit about the demographics that IIRRM physicians and the research that's being done. Every time I've looked on, the grand rounds topics or just the papers that are being discussed, I mean, it's everywhere. It's like, it's young girls, it's various reproductive diseases and disorders, it's male factor infertility, it's lifestyle factors that impact this, it's medications, it's treatments, it's just the breadth and depth it's just exciting, And again, I don't claim to understand half of the things I'm reading, but just the topics of the papers and the discussions, it's like, wow, there's so much going on, sadly, right? There's so much need and so much area that needs to be covered. But at the same time, there's so many great questions being asked and proposals for solutions. So maybe you can touch on that too. This isn't just for the woman who's in her early 30s experiencing infertility, correct?
Absolutely. So I would say a lot of it depends on with our physicians, what's their practice, right? So we certainly have, for example, in my practice, I'm doing RRM all day, every day. That's all I do. But there are many physicians in our organization that have full spectrum family medicine practices or full OB practices. And so it can really span. But a lot of what we're looking at within RRM does focus on, women that are having menstrual cycles across the spectrum. So I'm going to speak just from my practice. When I look at that, probably about half of the women and couples that I see I'm seeing them for fertility concerns, but easily at least another half of them are just coming from menstrual cycle concerns. Everything from the 13-year-old who's having painful periods and can't make it to school on a regular basis to the woman who's starting to go through that menopause transition and is having struggles, and everything in between. So really within restorative reproductive medicine, we look at kind of that whole spectrum from menstrual cycle concerns and fertility. And then the other that's very, very different, and a thing that a lot of people don't realize, is we absolutely also will address male factors, especially when it comes to fertility. Again, some of our physicians are practicing in regular family medicine clinics, so they may do more with male hormones in general. But absolutely realizing that is such a critical role to what we do, because we can't get there without having both sides of the couple evaluated. So that's at least within my practice. Dr. Parnell, you can explain yours. I know a little different demographics for you.
Slightly different demographics, because I've been doing this for several decades now, and my patient population has also grown. So I do not only the fertility and a lot of PCOS and, as you say, the menstrual cycle abnormalities, I also do the peri and postmenopausal patients who are looking for what is normal for my body hormonally at this stage of life. And that again falls under the umbrella of restorative reproductive medicine: is what is normal, what is not, what can we do to normalize your body so that you have health, that you feel good, and that you avoid some of the disease components that come about, or the unwellness that comes about from abnormal hormonal or reproductive aspects. I do also see a lot of male components as well, just because I've done it for a long time, and the men, they come in with the same things. They may not have a menstrual cycles chart, but they certainly have hormonal variations, and they want somebody who's actually going to listen to their issues. And I think we have to be aware that for both men and women, these abnormalities are not just inconveniences. They're not just, oh, well, then you can't have a baby. These have indicators for long-term health. Obviously, PCOS, there is a ton of work done on its link to heart disease and different cancers, tons of different abnormalities, diabetes that can come with PCOS. But for men, we also know that an abnormal semen analysis is linked to many years of less life. So they have a shortened lifespan, and they also have a lot more years of disease if they have abnormal semen analysis. And that was something published, I believe, by the WHO sometime in the last couple of years. So it's not just, well, they can't have a baby. Well, does it matter if their semen analysis is abnormal? It's a marker of health. And we really deserve to have well-functioning, healthy bodies. And biomarkers tell us that. We just have to know what they are and listen to them for both men and women throughout the life cycle.
I think both of you just summarized what, when we say restorative reproductive medicine, what do we mean? We mean that it's almost like a worldview, right? That the restorative reproductive medicine approach views the reproductive system as it has to be functioning in the way it was designed to function. So that means women are ovulating during their reproductive years, and men are producing sperm and have healthy hormone levels during their reproductive years, which is pretty much like everything once it starts, it's just like forever. And so anyway, I maybe that's an oversimplification, but if both of you can, either agree with that or elaborate on that. But when we say restorative reproductive medicine, how is that different from mainstream, quote unquote, medicine or non-restorative reproductive medicine? To me, it really hinges on that worldview, that perspective of like ovulation is a sign of health and you need to be ovulating. I don't care what your pregnancy goals are. You need to ovulate. It's good for your brain. It's good for your bones. You just need regular estrogen and progesterone throughout your reproductive years because you're going to need that in your postpartum years as you get older. It's good for your heart. It's good for all of these things. And the same for men. We want you to be healthy. We want you to be producing sperm regularly. We want you to have healthy hormones. And so that's kind of the worldview, the perspective of it is to keep the systems operating as they should and for as long as they can during that season of life. What would both of you say to that, Dr. Minjeur?
Yeah, I think, one of the things I say in my practice often is my first goal is always to improve your health. Because even if you come to me and you say, my number one goal is to have a baby, I say, that's really nice, but I can't make you have a baby. I can help to improve your health. And when we improve your health, your chances of having a baby will increase. Absolutely, right? When we restore that natural function, that's how our bodies were created, was to ovulate, to reproduce. And so when we can get back to that natural healthy state, no matter where we start from, we're always going to be working with that as our primary goal to improve health. And then I say, great, if there's a pregnancy along the way, awesome, we'll celebrate. That's great. But always with that first focus to be health, because again, I'm not setting you up just for this one event that we want to have happen. I'm also looking at, this 14-year-old who's not having cycles even after she was. I'm realizing that has a big impact on what happens with her bone health when she's 50 or 60. And, a 14-year-old doesn't think of that, but that's our job as these restorative reproductive medicine physicians, is to take into account the lifespan of our patients, not just the one acute event we're seeing them for. And so it really shifts it from this acute crisis Band-Aid care that we just slap a pill on and say, see you later, good luck, to really this long-term, how do we help improve the health of our patients for the rest of their lives?
I absolutely agree with Dr. Minjeur. This is longitudinal. This is not just a single point in that person's life. It is throughout the course of their life, and it really is about health and wellness. And I think one of the aspects that really helps us as RRM professionals is by defining the way we practice to not suppress, destroy, or circumvent the problem. Because I tell you, it was a lot easier to spend 5 minutes and prescribe the pill or, jump to IVF. It was much easier. But this way, we have to work to find out what the problem is. And that means we can address the problem because it is essential to how we help the patient. We don't have things that just are easy, but don't address that root cause.
I also think it's really helpful as the patient to hear that statement from, a physician. And when you're in a state of infertility and your goal is like, I want to have a baby yesterday, you kind of lose sight of like, I'm not able to get pregnant. This is a sign that I'm not healthy. Actually, I could look great. I could be eating all the good things, doing all the good things, but I'm not ovulating or something is off. Like, this is a sign that like I'm actually not healthy. It's almost like, people, I worked with individuals that have disabilities for a really long time, and some disabilities are very overt and you can see them, and it immediately kind of, the response is sympathy and empathy and, understanding, but it's kind of the silent ones that, it takes a little bit longer to kind of cultivate any kind of empathy or understanding, even for oneself. So I think having that rightly ordered idea of, to your point, Dr. Minjeur, like, yes, I would love to be able to get pregnant. That is a sign of health, that I have ovulated, that my husband has sperm, that they're able to meet and this baby comes into existence. Excellent. But really, like, I'm not healthy right now. So let's get healthy first. And then if I'm healthy, just kind of goes like in line, well, then pregnancy should kind of result from that. But there's a reason why this is not happening right now. And it's a sign that of, something is off and I'm not healthy. So were you going to say something, Emily? Okay. I'm going to jump into another question that I have. So, and this is maybe a little like in the weeds, but something I've been very curious about, because there's a lot of conversation about, IVF, and Emily and I have both encountered and worked with women who have maybe done IVF successfully or unsuccessfully. And we've talked about the rates of success of IVF versus restorative reproductive medicine approaches. Also the financial investment that you're spending on those two different approaches to trying to achieve a pregnancy. But again, this is just more like a personal nerdy question I've been really wanting to ask someone from IIRRM. And that is, if a woman is able to, because the success rate for IVF is just really not great. So for women who are able to achieve a pregnancy using IVF, and kind of like right out the gate, like every time they go and they have they have all the embryos created, and then they go back and they keep getting them, reinserted, right, to try to have that baby implant to get to a live birth. If a woman, sorry, I'm getting my question. If a woman is able to go through the process of IVF and come out the other side with a live birth, would you say, did she really need IVF to begin with? Because that's kind of what I thought. Is like, if you're able to like, baby latches on there in the endometrium, you're able to carry baby, you have a live birth, like, gosh, do we really need all of that to get there? And then it's more like the women who never have success with IVF that I'm thinking like, okay, there's something really big going on here. Like that would not work for you no matter how many times you did it. It's like the women who, well, we're trying to, achieve a pregnancy, but we're never having intercourse on a fertile day. It's like, well, then you're never going to achieve a pregnancy. So I don't know if my question makes sense, but I've just been so curious about that. And yeah, if you have thoughts or actual information on that, that'd be great.
Yeah. So, what we say is that the one time where we know that restorative reproductive medicine maybe doesn't work is if physiologically, biologically, anatomically, the right parts are not there. Female, male, anatomic, right? So we are very clear and obvious that when we're looking at things from our standpoint, we are looking at natural conception, male, female, right? So, when we look at those pieces, it's hard to surmise, hey, would it have worked anyways? Maybe, maybe not. It's hard to know. And really, when we look at the studies, that is one thing that we're really trying to get clear on, but it is really challenging when we compare studies looking at IVF outcomes to studies looking at RRM outcomes. We're comparing apples and oranges. So, for example, a lot of IVF studies will count a positive pregnancy only after they've seen a heartbeat on ultrasound. Whereas in RRM, we oftentimes will count a pregnancy when we see a positive pregnancy test, even if that's your home urine test. And so even some slight nuances like that make a huge difference when we look at outcomes. The things that we know that we do have as identifiable researched outcomes, that we have the research to back it, is we know that restorative reproductive medicine reduces the preterm birth rate by about half that of IVF. So we have a much, much lower preterm birth rate, which leads to healthier birth weights, less NICU stays, less cost, less problems as far as long-term health of that baby. We also know that we have less frequent twins, so about half the rate of twins as IVF. And again, twins are great. A lot of our patients are really excited when they have twins. But from an overall health standpoint, it can increase risk for pregnancies when there are twins. And again, this is almost universal across the board. It's at a fraction of the cost that we provide RRM care when compared to IVF. And so even if we just look at those pieces of it, we really are able to say, okay, it doesn't all line up with comparing the research across the board. But again, internationally, effective treatment strategy with half the preterm birth rate, a fraction of the cost, and overall healthier moms, healthier babies, healthier dads.
I do want to just answer a little bit about did they need IVF or not? Dr. Minjeur has very clearly outlined the types of patients that this just does not work for. We published a study in 2018 on a group of patients who had previously undergone IVF, on average, I think between 2 and 3 cycles of IVF. So this isn't just somebody who made one attempt, and different groups had different success rates, but the overall success rate for patients, and these were older women in their mid to late 30s who had been trying, I believe, between 5+ years. They had done multiple cycles of IVF, almost exclusively unsuccessfully, and over half of them were able to come and undergo RRM treatment, get answers, and have a live singleton healthy baby, despite their age, despite their underlying extensive years of infertility in their previous treatment. Now, what we don't know is, do patients who undergo IVF, is there things that IVF does that makes it more difficult for us to help with natural conception? That's possible. That isn't an answer we have yet, but we do know that patients are able to conceive with RRM after failed IVF, with, again, the exceptions that Dr. Minjeur mentioned, but this still works even for those hard cases.
Okay, so another, I guess, kind of nerdy question along these lines is, I hear a lot, and there's a lot of discussion right now, and I'd love to hear both of your perspectives on this, that infertility rates are on the rise. We're just seeing so much infertility. And again, another thought that I have had, which is, to what extent is that true, that there's so much infertility now compared to previous times? Or, we're also trying to have children later, like we're starting in our 30s versus our 20s. So is this really like a drastic rise in infertility? It could be a both and here too. Like, is this a drastic rise in infertility, or is this what fertility rates look like when you wait until you're 35 to start to have a baby? Does that make sense? Like, is this actually like a rise, or is this just what normal fertility rate looks like when you're of this age? Does that make sense?
Yeah.
Absolutely.
So I would say it's kind of falls more on your both and, is that, when we look at the causes of infertility that we find, there are multiple factors, right? So for our average patient with fertility diagnoses, in most practices, somewhere between 4 to 7 or 8 diagnoses that we find, right? And that can be a compilation of things, whether it's age related. Male factor is a huge role in this. When we look even worldwide, we know that sperm counts are decreasing. The way we have had to report and adjust our numbers as far as what's normal has changed, because we know that male sperm counts are decreasing. We don't know all the reasons why yet, but that plays a huge role. There's a lot of other factors we don't really have a pin on, like exactly why. So certainly age plays a role, and certainly to your point of, yes, that may be a part of it. I don't think that explains all of it, but we're still working to figure out the exact why. It's definitely not just one thing, though. We know that for sure.
Even in some of the research that is available, if you remove the age-related factor, we do see more women and men presenting with subfertility, with challenges getting pregnant. So it's certainly contributing overall, but it is not as Dr. Minjeur said, it's not or, it is both.
And
Well,
go ahead, Emily.
Oh, I was just going to say, and don't you think if that is a 30-year-old woman, for example, coming to try to achieve, it really matters what did she do from 15 to 30 to address her fertility issues at that point. And so I feel like just as everything is, every case is different, but it's definitely
Well,
and
we definitely seeing a lot more teenagers that are put on suppressive therapies like birth control that are on it for decades until they decide they want to conceive. So, we certainly do see that a lot more often. Even when I started in practice about 14 years ago, it was common, for example, you couldn't have an IUD put in unless you had already had a baby. And now IUDs can be put into teenagers, right? So even just the practices of some of those suppressive therapies are changing significantly. And so I think that does probably play a role and an impact on and it may not be the actual thing that we're doing, but we are covering up whatever issue is there, right? So if you are coming in as a teenager with irregular cycles indicative of PCOS, and we're just covering that up for 15 years rather than working during that time together to correct that, that is not restoring your fertility. So we lose that 15 to 20 years that we should have been working on restoring health, and instead we had just been suppressing it that whole time.
And this is where I think the joy of learning cycle charting is really a powerful tool for particularly young women. because you can identify at-risk cycles much, much earlier. Well, you can't identify them at all once you have urine suppressive therapy. As Dr. Minjeur says, it's a Band-Aid that covers it up, but it doesn't stop the underlying condition. And when you have cycle charting and body literacy, that empowers them to sort of say, hey, you know, I used to have cycles that were 26 days and I would have this great mucus cycle build up, and now I'm not having that. I'm having brown bleeding. This is a change. What's going on? And they have the opportunity to engage in discussion about what's causing that. And that gives them more options to be able to recognize what may impact their fertility in future.
Yeah, it's so exciting. I know that something Emily and I talk about almost ad nauseum on the podcast is just how, you know, as an NFP teacher, you get into it, you start teaching, you just encounter like 30-year-old after 30-year-old after 30-year-old who's like, I didn't know this about my body. Why didn't I know this about my body? And you're immediately just switch to like, oh my gosh, how can we teach young girls about this so we can stop hearing as you get older that you just didn't know how your body worked. You know, it's such a disservice. And at the same time, we always say this too. We recognize like when you're a mom and your young 13-year-old daughter is missing school and she's in a lot of pain every cycle, and someone offers you something to just like squelch those symptoms and you don't have other options and you don't know about other options, you know, I really don't fault you for that. Like, I get it. You don't want to see your daughter in pain. It's just more of, you know, well, can we find a solution that we can still address the symptoms and the pain, and we can get to the why the pain is happening and correct that now. So, you know, regardless again of pregnancy goals, even in the present or in the future, we can just get her ovulating and having healthy cycles, because as one of my favorite doctors, Dr. Laura Bryden, a naturopath, always says, like, a period should be a non-event. It kind of should come and it should go, and it shouldn't interrupt your daily life. And that, I think, is something that's just mind-blowing to a lot of people, a lot of women, because for most women, you know, a period is not a non-event. It's a very big event, a scary event in some cases, depending on the level of pain. So I guess I'd love to wrap up, and thank you both so much for your time. This has been so great. I'd love to wrap up hearing from both of you, you know, what's kind of happening right now in the RRM world, whether it's just research or in your practice, what's getting you exciting, what is, you know, new information to you that you're kind of exploring in your practice, just to kind of give us a little bit of an insight and a foreshadowing of, you know, things that are coming or things that medical professionals are working on and investigating. So Dr. Minjeur, let's start with you.
Yeah, I think one of the most exciting things I see in my practice is that women are referring other women to see us. You know, I don't spend hardly any time trying to get referrals from other doctors. I mean, I do work on educating the doctors in my community and in my state and nationally as far as what I do, so that hopefully we'll get other people doing this. But women are talking and they are saying this is such better care, and they are coming by the droves, which is amazing. And the other is that even if it's women who aren't necessarily seeking out RRM care, we are empowering them to go back and talk to, you know, their primary care doctor or their OB and say, this is the kind of care I'm receiving. Isn't this amazing? Would you like to learn more? I'd like to share more with you. And we're really seeing this flip of the doctor is right all the time, they know everything, to really women are being empowered to ask more questions, to understand their body, to feel comfortable asking these questions that otherwise some women have truly been just gaslit for years when it comes to their medical professionals. And I'm really, really enlightened to see, like, oh, I love when we're empowering women. That's ultimately our mission. The other that's really big in my clinic is a couple of my charting instructors that work with us have really taken it upon themselves to educate young women in our communities. So one of our charting instructors goes out and she actually talks to young women even before their periods start. So like 8, 9, 10-year-olds, talks about cycle prep. They go out and they're doing education to teenagers, to middle schools, to high schools. And really, to your point, let's get this education out to these young women and really realizing we have to turn this generation around, because even for many of us that have girls that are that age, we didn't get this education ourselves. So we always lovingly say it's the education we would have wanted ourselves 20 years ago. And so really seeing this movement coming from within and women really bonding together and creating these communities where we do have this empowered education and this interface of being able to talk with our healthcare professionals about it. And that just gives me so much joy and really just keeps me powered to go each day.
Yeah, so hopeful. How about for you, Dr. Parnell?
Well, I echo what Dr. Minjeur said. I mean, the patient voice, the patient demanding for answers is becoming a tsunami of interest. I also have to say that the interest in the United States that has been generated by your president's statement about wanting more babies has actually elevated the discussion about restorative reproductive medicine and IVF and all those questions to a level that really hasn't been discussed prior to this. So we're kind of excited about that as a profession as well.
Oh, that's really interesting. Yeah, I hadn't thought about that. Okay, this has been so great. Thank you both so much for your time. We will be linking a lot of those resources that have been mentioned, as well as just the IIRRM website for those that are interested in learning more information. And please stay tuned in the future if you are interested in, diving a little bit more into specific reproductive disease and disorder and looking at solutions and kind of underlying causes and things. We hope to be having on some more RRM physicians to kind of go into those specific cases. So thank you, ladies, so much for your time. We really appreciate it.
Amy, I have
Thank
a
you.
question.
Oh, I'm sorry, Emily. Yeah, go for it.
No, it's okay.
Okay.
I just was going to ask really quick. So if someone is going to the website to fill out the form to get information to be connected to an RRM doctor, are there telehealth options for okay, that's great.
Yeah. No, RRM isn't available every single place in person. I think most of the United States, again, we are a global organization, but most of the United States has access either via telehealth or in-person clinics or relatively short distances to be able to access. We'll do our best, again, to connect you with the right person in the closest location for you.
That's wonderful. Thank you.
Thanks, Emily. That's a really great question. And keep in mind, IIRRM is not religiously affiliated. They're not method affiliated. They are just looking at ways to keep the reproductive cycle working as it should and trying to find underlying causes and solutions to better serve their patient populations. So thank you, ladies, again so much for your time. And good luck in all of your great work. Thanks for everything you're doing.
Thank you.
That wraps up another episode of the NFP Podcast. Thank you so much for joining us today. We hope you found our discussion enlightening and empowering. Don't forget to subscribe so you never miss an episode. We'd love to hear from you. Please connect with us by sending us an email with your questions and stories to thenfpshow@gmail.com. We'll be back next week with more insights, tips, and heartfelt conversations about natural family planning. Until then, love responsibly.